Welcome to our panel discussion on Bridging the Gap, Advocating for Better Nasopharyngeal Carcinoma Patient Care, an initiative of Voice of Healthcare. Nasopharyngeal carcinoma, that is NPC, patient care involves improving early detection, access to advanced treatments, and comprehensive support systems. Increased awareness and patient centric policies are really crucial. By addressing these gaps, we can enhance survival rate, reduce disparity, and improve quality of life for NPC patients. To share their views, we have with us Dr. Sanjay S. Rai, Head of Department Medical Oncology at Employees State Insurance Corporation, Faridabad. Welcome, Dr. Sanjay.
Sure.
Hello, Dr. Manisha. Thank you very much.
Welcome. We have Dr. Amit Sherawat, Associate Professor, Medical Oncology, AIMS, Rishikesh. Welcome, Dr. Amit.
Hi, good evening, ma'am. Thank you. Thank you for inviting.
Welcome, sir. And we have Dr. Pulkit Nag as well, Consultant Medical Oncology and Hemato-Oncology, Apex Hospital, Jaipur. Welcome, Dr. Pulkit.
Well, thank you so much and very good evening to everyone.
So I'm Dr. Manisha Khurana, and on behalf of Voice of Healthcare, I thank you all for being here. So my first question goes to Dr. Sanjay, that how does the prevalence of nasopharyngeal carcinoma, NPC, vary across different regions of India, and which states or populations are at high risk? Dr. Sanjay.
Nasopharyngeal carcinoma is as such a problem of Southeast Asia, some parts of Africa and Arctic region, not very common in India. However, the cancer registries of India, they have shown that there is more incidence and prevalence rate in northeast region of India, especially Nagaland, Manipur, and Mizoram, all these areas. And the thing is, in these areas, there are some ethnicity which shares ancestry or inter um, ethnic marriages having Chinese antecedent origin. So, in this group of ethnicities, there is more prevalence of ABV virus, and there are some other factors which are unknown. So there is high incidence in these regions of India as compared to other parts. Like in Mumbai, if we see the incidence is rate is less than 1%, around 0.3 per 1 lakh. But when it comes to Nagaland, it goes to like 4 per lakh, or age adjusted incidence rate is in like 19 cases per lakh. So it is more common in northeast region of the country.
And what are the factors contributing to relatively high prevalence of NPC in Northeast India compared to other parts of the country? Dr. Amit, could you answer this question?
So, like sir already said, this malignancy is relatively common in just certain part of the world. Classically, like in our textbook, say it's the south part of China. There is the highest incidence of this malignancy in the world, around 25 per 100,000, as compared to the rest of the world that is a rarity, 0.2 to 0.5 cases per 100,000. So that means there are certain endemic regions for that particular malignancy. There are certain regions which are local regional regions which are more common in that particular local regional aspect of the globe. So because that part of India, northeast part, is more close to the southern China part, that means there is some geographical association, and that is directly linked to ethnicity that sir already said. Other important component of that understanding the etiology is EBV virus exposure. So this is classical association of EBV virus. So that is more common in that part of India. So higher incidence. Also the smoking. And third most important point is the type of dietary habits that that part of India is having. More preservative, more salty fish. That is a classical association with nasopharyngeal carcinoma. So the kind of dietary habit we are having, the kind of genetic that they are having, the kind of EBV endemic area is there. So there are so many permutation combinations that makes northeast of India as kind of a most common incidence that happens in that part of India.
Right. And as we know that it's an orphan disease, NPC, so why is it called the orphan disease, and how does it relatively low incidence impact the research and treatment development, Dr. Pulkit? Dr. Pulkit, could you answer this? We can't hear you, sir. Dr. Pulkit? I think we have lost him. So I would ask again, Dr. Sanjay, the next question. What are the key clinical symptoms that may indicate nasopharyngeal carcinomas? So please unmute yourself.
No, I am.
There is no.
Can you hear me now?
Yes, Dr. Pulkit. So Dr. Sanjay, I will
Okay.
definitely come to you again. Let me go to Dr. Pulkit. So Dr. Pulkit, we know that nasopharyngeal
Yeah.
carcinoma is an orphan disease. And why is nasopharyngeal carcinoma considered an orphan disease, and how does its relatively low incidence impact research and treatment development?
So we've already discussed that nasopharyngeal carcinoma is low incident and found in the region of northeastern Hong Kong and China. And because of the different dietary habits and genetic factors, that's the major causative agent for this nasopharyngeal carcinoma. Since the incidence is low and the number is low, that's the reason it's called as an orphan disease. And that is the reason, since we don't have too much of patients to do the scientific research on. And that is the reason that there is a delay in finding more advanced treatment for nasopharyngeal carcinoma. So I think these are the two major causative factors for it.
And Dr. Sanjay, please tell us the key clinical symptoms. We want to catch it early, nasopharyngeal carcinomas.
Patients with nasopharyngeal carcinoma, they don't have any straightforward symptoms pointing to the disease, but yes, that they have symptoms which can mimic any other disease also, like they can present with headache, they can present with blurring of vision, they can present with nasal bloody discharge, nasal blockade, and nasal stiffness, and they can present with ear pain also. They can present with lump in the neck, both side or unilateral sides. They can present with difficulty in swallowing. So all these symptoms which they can present can occur in any other disease also. So hence sometimes there is delay in diagnosis also.
Right. And Dr. Amit, why is early detection of nasopharyngeal carcinoma challenging?
Uh, as sir already pointed out, the kind of symptom we are expecting from nasopharyngeal cancer, they are not specific to nasopharyngeal cancer. They are just vague symptomatology. That's the first thing. Secondly, the location of this disease is kind of a hidden location. So that is not obviously visible. Like in all head and neck malignancies, if there is some oral ulcer, that is immediately visible. The symptoms are immediately presented to physician. But this is kind of hidden location of the disease, the fossa of Rosenmuller, nasopharynx. So even if there is some disease, the symptom onset and the onset of disease, there is a lag period between them. So usually the symptoms are delayed. That's the first thing. Number two, symptoms are not specific. That's the second thing. Third, symptoms usually arise from the invasion of surrounding structures. The primary disease might not have any symptom. For example, the first symptom can be because of cranial nerve involvement. So it's become very difficult. So vast majority of the patients, especially in Indian setup, they present in locally advanced disease. The lesion visible to regional nodes or cranial nerve involvement. So that makes it very difficult to diagnose in early stages. And vast majority of the patients, they present in locally advanced or advanced metastatic.
Right. And Dr. Pulkit, what are the diagnostic tests essential for confirming NPC, and how do they contribute to the diagnosis?
So I think all the clinical symptoms which being shared by Dr. Sanjay sir is like if patient present with all these symptoms, the first test we go is radiology. So if we have a clear-cut mass visible in the nasopharyngeal or the parapharyngeal region, we go with the guided biopsy to check the kind of histology, because nasopharyngeal carcinoma histology is different from squamous cell carcinoma of other head and neck cancers. So first is the biopsy to confirm, and as once it is, even if the mass is not visible and the symptoms are clearly depicted, then we can also go with the frank biopsy from the region of fossa of Rosenmuller. which is the most common site for nasopharyngeal carcinoma. And third is, if you want to confirm the causative agent, then Epstein-Barr virus can be searched either on the tissue by in situ hybridization, or also in the blood with the help of PCR technology. Yeah.
Right. And does detecting Epstein-Barr virus help in monitoring the disease?
Absolutely, yes. I think there is a study which shows that if the EBV titers done by the PCR, the DNA titers, if it is greater than 4,000 before starting the treatment, even especially for stage 2 and stage 3, the chances of distant metastasis almost get double. And if we give the treatment to the patient, and post completion of the treatment, if the residual EBV DNA titers are around 400, then also the chances of relapse almost get double. So either before treatment, after treatment, if possible, we should also have an quantitative EBV DNA analysis done, and which definitely helps in the prognosis as well as deciding the higher chances of relapse to the patient.
Right. And Dr. Sanjay, what are conditions which are there for the differential diagnosis of nasopharyngeal carcinoma, and how can they be distinguished from it?
If we find some tumor in the nasopharyngeal region without any lump in neck, then we have to consider both like malignant condition as well as benign conditions also, like enlarged adenoids or some nasal polyps. Then some malignant condition like lymphoma and even benign inverted papilloma, juvenile angiofibroma, some vascular malformations, sometimes head neck, other cancers also, they can go upwards to nasopharyngeal region. So in neck, sometimes patient only present with lump in neck. So in neck, there is lymphadenopathy generally. So there are other regions of bilateral lymphadenopathy, other carcinomas like oral cavity or tongue. All these can present with metastasis to neck. So sometimes even I have seen this nasopharyngeal carcinoma directly presenting with pancytopenia rarely. So bone
Okay.
marrow test was done and the diagnosis came from bone marrow of nasopharyngeal carcinoma. This
Is
also
it?
has happened with, yes, yes, yes.
Okay. Right.
So
So,
this
Dr.
tumor has tendency to go to bone marrow. It's very common. Yeah.
So, Dr. Amit, what are the primary treatment options for nasopharyngeal carcinoma? What are the choices of treatment available?
So, like elsewhere, the treatment plan depends on the stage of that we are dealing with, patient profile and stage. So that actually depend whether patient is having localized disease, locally advanced, or advanced metastatic disease. However, there is one specific difference how we are managing nasopharyngeal carcinoma as compared to the rest of head and neck malignancy. That access, the surgical access is very difficult, nearly impossible surgical access with cosmetic outcomes. So that's why surgery is not standard of care even in early stage nasopharyngeal carcinoma. The backbone of therapy remains radiotherapy. The radiation is the essential treatment modality in vast majority of nasopharyngeal carcinoma. So if stage early like T1 N0, T2 N0, radical RT or in some cases CT-RT remains standard of care modality. If slightly locally advanced disease T3 N0, T2 N1, then there is some role of induction, but vast majority of the patient they are treated with concurrent chemoradiotherapy. That means chemotherapy along with radiation. However, this kind of cases are relatively lesser common in Indian setup. So in our setup, most of the patients they present in the locally advanced setting. In that case, now standard of care is induction chemotherapy followed by chemoradiation. So there is a newer set of evidences that we are recently having from China that gemcitabine plus cisplatin-based induction chemotherapy followed by concurrent, that is current standard of care as of now. Till recently, we used to offer even concurrent CTRT followed by adjuvant chemotherapy. That's also one of the option in a certain set of the patient. And there is also one specific difference as compared to rest of the head and neck malignancy. Even in advanced metastatic patient, when we are having advanced spread of the disease, there is role of induction chemotherapy followed by local consolidation with RT and maintenance chemotherapy, single agent capecitabine. So even in stage 4 advanced metastatic patient, there is some role of radiation. So radiation remains integral therapy. Vast majority of the patient they get benefit with induction therapy. So even in advanced metastatic setting, after concurrent chemotherapy or radiation consolidation, there is a role of some maintenance chemotherapy also. So that is the kind of backbone of management for vast majority of the patient.
Right. And Dr. Pulkit, how is treatment response and disease recurrence monitored in patients of NPC? Dr. Pulkit, please unmute yourself.
Yeah, so basically we monitor the response on three broad categories. One is the clinical response, which we do it in every cycle of chemotherapy with the patient when they show of the relief of the symptoms they already had at the baseline. This is how we monitor clinically. Second, we do a radiological response when compared with the baseline imaging with the imaging post neoadjuvant chemo or CTRT. And third, as I already told you, is the EBV DNA titer response. So if the if the patient has the baseline EBV IgA titer available with us, we can monitor on biochemical level and see whether the titer at the baseline has decreased significantly or not. So I think clinically, radiologically, and biochemically, these are the three parameters in which we can monitor the treatment response to the patient.
And Dr. Sanjay, since we know that there are so many immunotherapies coming, and PDL1 immunotherapy is one of them. So, how does PDL immunotherapy play a role in treatment of nasopharyngeal carcinoma, and which patients are most likely to be benefited?
Majority of this nasopharyngeal carcinoma, they are driven by EBV antigen. So the thought is that all like viral driven cancers, there should be a role of immunotherapeutic agents. So when this uh, WHO category, WHO 2 and 3 nasopharyngeal tumors, they were studied, they are mostly EBV driven. There were immune related inflammatory cells, but surprisingly, cytotoxic T cells were not working. They were inhibited because of more expression of PD-1 receptors. So then now we have immune checkpoint inhibitors which are targeting this axis, PDL1 ligand and PD-1. So immune checkpoint inhibitors were tried. Initially, there are results of nivolumab, pembrolizumab, and there is more robust data with toparilumab. This is Dr. Reddy has recently imported from China. Toripalimab is there are two trials in which US FDA has approved. One is Jupiter 2 study and another is Polaris 2 study. In Jupiter 2 study, patients with advanced and recurrent metastatic nasopharyngeal carcinoma, they were studied along with gemcitabine and cisplatin, and there were more progression-free survival benefit of like 11.7 months versus 8 months, and there was overall survival benefit also. And in second study, Polaris 2, this toripalimab was studied as monotherapy after failure of platinum-based chemotherapy. And there also there were response rates of around 21%, and there was a median disease control was seen. And both the drugs are FDA, both the situations are FDA approved now recently.
And could you tell us that how has the introduction of immunotherapy contributed to increased survival rate of patients with nasopharyngeal carcinomas?
With chemotherapy, the uh, progression-free survival was less, like 8 months. And with the addition of this immunotherapy, there was roughly 11.2 months of benefit, which was more than the chemotherapy.
And I would like to ask my next question to Dr. Amit, that do you think there is any role of genetic predisposition or family history in nasopharyngeal carcinoma?
So, as we have been discussing over last few minutes, so this is a classical association of EBV predisposition, infection, and then development of malignancy. And there is also some endemicity. So, one particular part of world, one particular part of India is more likely to have this kind of malignancy. That means there is it's a kind of there are certain family clusters. There are certain areas, certain groups of population, they are more likely to have this malignancy. So that means there is some genetic association also, but there is no classical familial association. There is no classical gene mutation that is associated. So it's most likely that there are certain geographical regions which are having exposure to EBV virus. They are having certain lifestyle things. For example, salted fish, which is more commonly consumed in certain part of India, in northeast specifically, and higher incidence of smoking. So there are so many permutation combination which intercalate and increase the incidence of nasopharyngeal carcinoma. So that's why if we are planning to do some kind of screening modalities, so we need to target populations, and in that targeted populations, we can screen the particular clusters. In those clusters, we might find a relatively higher incidence of NPC.
Right. So, Dr. Pulkit, my next question would be that have you seen any emerging trend, increase or decrease in nasopharyngeal incidence over the past decade? And how might they have our future prevention strategies evolving?
So I think there is a dichotomy in the answer. So if practically speaking, the incidence has decreased because it is being seen that the consumption of salty fish and the preserved foods have decreased in the northeastern region as well as in the Hong Kong and the China side. So these factors have on one side it leads to the decrease in the incidence of cancer. But on the other side, it's because of the availability and the awareness, carcinoma, now people are more aware. So the diagnostic facilities have improved, so they can be easily detected. So on that part, we could see the more cases because we are now aware more. But overall, if we talk about the predisposing factors on that part, the incidence has decreased because of the less consumption of fish and preserved food, more awareness regarding smoking and tobacco consumption. Yeah.
Dr. Sanjay, do you believe that artificial intelligence and machine learning it is helping us in any way in early diagnosis of NPC, especially in pathology and imaging? Dr. Sanjay, please unmute yourself.
AI has a role at many steps, beginning from the diagnosis. Initially, at microscopic level, when histopathology is analyzed, then from remote place, microscopic data can be uploaded and AI can analyze. If there are no expert pathologists, then also we can get good reports. And then there are when we are following with EBV, the plasma DNA titers also, that time also AI can help us in making the plan. And in treatment also, in future clinical trials, there can be proteomics studies where AI can develop newer formulations which can act on these malignancies. So AI has a role in selecting the drug also in diagnostic stage also. Yes, of course.
Right. And Dr. Amit, what are the present, screening methods, and how do you think that we can improve on for the early detection of NPC?
So since this is, as we are discussing, this is an orphan disease. So this
Yeah.
is not a major public health problem as such. So there are no certain set of guidelines to screen as such from Indian point of view. So as such, there is no standard. Whatever head and neck malignancy screening methods we are using, the population orientation we are doing, that is applicable for nasopharyngeal malignancy also. For example, we need to train the population that if there is any new lump in neck, if there is any change in voice, if there is any recent onset epistaxis without any specific reason. So if there is any new red flag sign, so instead of just waiting for symptom to get worsened, we need to approach our healthcare facility, nearest healthcare facility as soon as possible to see whether there's a malignancy associated symptom or anything known.
Right. And Dr. Pulkit, since we know that primary healthcare worker play a major role and to catch the disease early on, so how can we improve their active role in identifying potential NPC cases before referring it to the specialist?
So I think nowadays social media has its own plus and minuses. I think the awareness on the social media through the newspapers. Now a lot of doctors are active on the social media to spread awareness. the kind of program we are doing right now is a kind of awareness regarding the esophageal cancers. So I think the primary health worker, if not too much educated about in detail, I think because of all these platforms, they can be very well aware regarding the symptoms, signs of nasopharyngeal cancer. Because a medical oncologist or an oncologist almost 99% get a patient referred from somewhere, because the patient is not educated enough to understand whether he or she is suffering from any nasopharyngeal cancer, or whether, as sir has mentioned, that some symptoms can be because of the involvement of cranial nerves. So you cannot connect those symptoms to a classic head and neck cancer patient. So I think because of this, the awareness through social media, to newspaper, through all these channels, healthcare workers should be aware and educated. We can conduct some small classes for them to make them understand in a very layman language what are the exact signs and symptoms of esophageal cancer. So the yes, the primary key healthcare worker do play an important role, and I think it's a responsibility to educate them as much as possible through every possible media.
Right. And Dr. Sanjay, are there any more targeted therapies available for NPC?
There are studies being carried on regarding cancer vaccines also, dendritic cell vaccines in this area, adaptive cell therapies also, because this is mostly a immune driven malignancies. So in near future we will come up. There may be some other options also for this disease.
Right, sir. And my next question would be to Dr. Amit. What are the most effective way of the or the strategies you can say for raising awareness about nasopharyngeal carcinoma in the region with especially high prevalence, like Southeast Asia and parts of India?
So in our context, that is area is northeast of India. So in northeast of India, we need to, for example, we can take a case, nasopharyngeal carcinoma case in one particular vicinity. So that means that particular area is kind of having endemic EBV rates. So we can screen that population, we can orient that population that there is one kind of malignancy which is more likely to occur in this population. So if there is any patient, any person having neck node, neck swelling, recent onset weight loss, there is some change in difficulty in nasal stuffiness, any nasal bleeding history, it's any kind of symptom that can suggest that there is some likely NPC, nasopharyngeal carcinoma-like symptoms. So such patient can be early referred to local healthcare facility for at least one basic ENT evaluation. And if there is any doubt, further proper oncological workup can be planned accordingly. So that means we need to target those population subsets where there is relatively there, for example, there is some family cluster where they are having nasopharyngeal carcinoma. So we can target those who are surrounding him, the family members, uh, in the vicinity, those patients, vicinity known population where we can target for orientation and early reporting to local health.
Right. And Dr. Pulkit, that how can collaboration between government, health programs, and NGOs and media enhance public awareness and early detection of NPC?
So I think the media part have already covered, like how the different awareness program as we are doing right now could help people to understand, and rather NGOs, because there are a lot of NGO people which come to our hospital for screening purpose, for understanding, and these are the bodies who are attached to the rural population and the ground level population a lot. So I think if a few 10 to 15 good NGO members could be invited to our hospital, and we can educate them, show some videos regarding the common sign and symptoms to them regarding esophageal cancer, as well as the government bodies concerned, then through the newspapers, through some health magazines, to write a special article on esophageal carcinoma, why it is more common in northeastern Asian region. I think all these parameters can help to reduce the incidence of esophageal cancer.
And Dr. Sanjay, do you believe that telemedicine is playing any part?
Telemedicine can help primary healthcare workers, but in screening, I believe at in high risk cases, high risk population, there are role of EBV plasma DNA testing also. So if there is high load in those population, we need to follow up them carefully. And there are people within this group, they develop nasopharyngeal carcinomas.
And Dr. Pulkit, could you tell us about certain advocacy groups? How can they help us in decreasing the financial burdens and support the patients who are suffering from NPC?
So I think in Rajasthan, since I'll talk about my state, we having a lot of government yojanas and schemes, which has helped at least including the chemotherapy part for the patient, and also the radiation part. I think both these part are being covered in the government schemes. We have a lot of empanelment available for the patient through which all these treatment can be reimbursed. Also, especially mentioning for toripalimab, which is being introduced by Dr. Reddy. I think they have introduced some wonderful scheme of giving few injections and then patient can be kept on some clinical program in which they can receive the expensive drug for a long time. So I think one is there, and also I think nowadays we should also educate the patient and the relatives regarding some Mediclaim policy also, because I think since the rising incidence of cancer burden is increasing so much, so I think educating patients regarding the various health TPA policies and with the help of the government schemes, this can be help in by addressing the financial burden of the patient.
Right. And Dr. Amit, what do you think are the challenges of conducting the clinical trial for NPCs in India? And how can we overcome that?
So challenge is like we need to have uniform patient and at least some incidents so that we can recruit the patients. So our recruitment are a major challenge. So because of relative rarity of the disease. So for example, if we are dealing with just a local regional in a northern part of India, so that study must be multi-centric study. So there need to be motivation, orientation of multi-center involvement. Single center nasopharyngeal carcinoma, say recruiting 100 patients is practically not possible. So there should be a multicentric approach. There should be a collaborative approach so that we can pool up our patients and we can plan something locally. So for this group of the patient.
Right. And Dr. Sanjay, could you tell us your views on what policies are needed for better detection, for supporting the group financially?
For clinical trials, this has to be a multi-center study where multi-centers of the country has to come together, especially the centers located in northeast region. They have to collaborate with other parts of the country, and there can be a data for like we have for rare diseases. There can be a data setup where cases can be uploaded and overall uh, burden of the uh, malignancy can be studied. And because this is a rare disease, so ultimately if we don't have enough number of cases, the trial results will not be applicable to wider section of the society.
And I would like to have everyone's view about how can we increase the awareness. So I think Dr. Pulkit has given us some insight. I would like to ask Dr. Amit the same question.
So I think Dr. Pulkit summarized it very well. So we need to involve local NGOs, local publications through social media, like this kind of event that we are conducting right now. So number of such events can be increased. Involvement of local FM, for example. There are certain, for example, if I am practicing in Uttarakhand, in the distant Uttarakhand population, might not have even access to electricity. So radio access is very important. That is also applicable in northeast of India. So awareness program through radio, local television, through magazines, publications, through local health societies also. We can, for example, we can train local ASHA workers in northeast of India, so they can be more motivated to early detect the sample and report to local health authorities.
Right. And Dr. Sanjay, what are your views on this?
Yeah, we need to do propaganda like mass uh, like radio awareness or newspaper or some television channels, and local healthcare workers can be educated. Even we can help them by telemedicine support from the government centers. So awareness is important, but yes, that is more better if we do it in a high risk population where it is more common, so that will help more.
Right. And Dr. Pulkit, can are you there? Yes.
Yes, yes, I'm there.
So
Am I audible?
yes. So
Yeah.
again, I would like to ask you that if you want to add anything about PDL1, checkpoint inhibitor, which has just been introduced, your views on that. Have you used it for your patients? What are their survival rates? Have you seen any improvement, please?
So I have one patient being started around 2 months back on toripalimab, and the patient was having a baseline intracranial extension of the disease, so almost stage 4 patients, and even the ophthalmic nerve was involved by the nasopharyngeal mass. It has eroded the pterygoid plate also, and after that, initially 3 cycles I have given the chemotherapy before the drug was launched, and after that I have combined it with toripalimab, and the result is phenomenal. Now the patient, the eye deviation has reduced, the symptomatic burden has decreased very well. So I have not got the PDL1 done for the patient because I think it is irrespective of the PDL1, the use of toripalimab. So I think till now in last 2 to 3 months the response has been phenomenal with the use of combination of chemo plus toripalimab.
Right. And Dr. Sanjay, could you tell us that what global initiatives can be taken for combating NPC?
There are endemic areas in the world, like Africa, and there are areas where it is NPC is more common within families also. So there is endemicity as well as there are hereditary regions also. So across the world, uh, EBV infection, which is more common, we need to monitor that, and there has to be a solution to reduce the spread of Epstein-Barr virus related infection. And there are other malignancies also associated with this. So overall, that will have an impact in the reduction of the incidence of NPC patients.
Dr. Pulkit, could you tell us that what are the most exciting, research areas in NPCs?
So I think the most exciting research areas currently is immunotherapy because it's being almost a 7 to 8 years of a gap because almost all head and neck cancers have been using pembrolizumab and nivolumab. In Even they have switched the role to new adjuvant settings in other head and neck cancers for immunotherapy. But I think the major turning point is the launch of immunotherapy, especially for recurrent and metastatic head and neck cancers, nasopharyngeal cancer patients. So I think the era of immunotherapy and having a specific immunotherapy drug exclusively for nasopharyngeal cancer among all the other head and neck cancer, I think that's the major development in this case. And also the early detection because of the awareness and radiological advancement has also been helped to treat nasopharyngeal carcinoma at an early stage. Yeah.
Dr. Amit, I would like to have your comment on PDL1 immunotherapy. Have you used it for your patients and what are your views on it?
So since I am working in academic center with limited resource facilities, so I am using immunotherapy in head and neck cancer, but my most of my patients they are getting low dose immunotherapy, the team triple metronomic chemotherapy plus nivolumab. That is the kind of immunotherapy that I am offering to my patient. But with the kind of patient assistance program that Dr. Reddy's lab is offering, so maybe in near future those patients who are affording middle class, upper middle class, they will be able to afford the PDL1, and data is extraordinary. So relatively, for example, in first line setting, if you are getting a PFS of 21 month, so that's extraordinary data. So it's a promising drug, and let's see what Indian experience is going to evolve over the next couple of years or so.
Right. And could you tell us that what are more exciting research areas?
So, for example, if this malignancy is having one classical association with one specific virus, EBV,
Right.
so we can target the TB virus. So certain investigators they are evaluate kind of investigating that aspect of the disease. If there is some virus is involved, so that means that we can target that virus specific antigen also. There can be a therapeutic modality which is going to target specifically that malignancy which is associated with EBV, and in this context is going to be EV associated nasopharyngeal carcinoma. Here we can target the proteins that are expressed and associated with EBV, and so that we can have more specific precision medical medicine like approach in this setting.
So my last question would be to every speaker, and I would like to ask you your comments, your views that how can we make the drug available to each and everyone? How can we make it accessible? What initiatives should be taken? So first, I would start with Dr. Sanjay.
I'm treating insured patients, so at my centers, uh, drugs shouldn't be an issue. Only thing that since disease is rare, so we have less number of cases for this disease. But availability of drug is not a problem. All patients are insured. So whenever there is an indication for treatment with this immunotherapeutic drugs in nasopharyngeal carcinoma, we will be able to use that.
Right. And Dr. Pulkit?
So I think one important part about toripalimab is that the cost is pretty less as compared to other immunotherapy. So I think this is one of the most promising factor which has helped for patient to select this drug. And the patient support programs which are being launched by different companies for immunotherapy, I think that has really helped the patient to, because immunotherapy is a slow acting drug and we need to continue it for a longer period of time. It's not a 6 cycle game. It's a long game for 1.5 year until the disease progression, most of the cases of stage 4. So I think more and more patient support programs are usually very helpful in which will help in availing the drug more and more to the patient. And as I have told you in the previous talk also, that educate the patient regarding getting more and more medical health policies in advance to prepare for the better management of disease in the future. So I think these are the two major things which can help to make drug more and more available to the patient.
Dr. Amit, please, your views.
So we can try to integrate this into the government supported insurance program. For example, there are so many states, they are offering some additional benefit other than Ayushman Bharat. Integration of local state health program and Ayushman Bharat can support, say, 10 lakh in certain states, 25 lakh in other state. So that means there is some scope for that kind of highly effective drug to be approved and made available through government sponsored program like Ayushman Bharat or integrated state and Ayushman Bharat programs that various states are providing. So in that way, we will be able to cover most of the patients of nasopharyngeal carcinoma, because vast majority of our population, they are not affording, especially in northeast of India, where the incidence is highest. The population is not affording anything. So if we are able to integrate this kind of treatment plans in state-sponsored health insurance plan, then maximum majority of the patient will get some benefit.
Right. We have some live questions as well, and one very exciting question is that there is proton therapy coming up. So I would like to ask Dr. Sanjay that how is this different from the conventional radiotherapy, which is given for head and neck cancer, and especially in NPCs?
Proton therapy is like that is less toxic and there is sparing of normal organs. So long-term toxicity with this proton therapy is better as compared to conventional radiotherapy, as well as there are some better efficacy results also with this therapy. So there will be, if there is a malignancy and if proton therapy is being given in that situation, so the result of getting cured will become more higher with this proton therapy as compared to conventional radiotherapy, and late toxicity will also be lesser.
Right. And anyone else wants to add anything? Any view, Dr. Pulkit?
So
Your
I
view
think,
on
yeah, the
proton?
major benefit of radiotherapy is a major carcinoma, and the major benefit of proton therapy, it has a more precision towards targeting the tumor tissue and protecting the normal tissue. So I think lesser of the side effect, more precise approach. That's why I think it is going to play a major role in the future and now also in the management of nasopharyngeal cancer.
Right. Dr. Amit, your views on this?
There is a concept of organ at risk in radiation. So that location that nasopharyngeal carcinoma is having, the surrounding organs are very crucial. For example, eyes. So the major advantage of proton therapy is that it avoids radiation to the surrounding structures, surrounding organs. So that's why theoretically there is much better safety profile with proton beam therapy. However, the data on survival, that whether that is doing extraordinary high as compared to the standard of care EBRT and other modalities, that has not been validated as of now. However, the information that we are having as of now in 2025, that it's a relatively safer option, but whether the efficacy is going to be same or high, that need to be studied in a prospectively designed randomized controlled trial. So currently there is no data that supports that proton beam therapy is going to be superior than whatever we are using right now in 2025. But in future, we might have some kind of evidence that can suggest other than safety profile, that can also have some better efficacy also. But that's a future prospect.
I would like to ask backend team if there is any other live question, please display on the screen. So, what promising treatment is available for treating NPC when disease spreads? Uh, Dr. Sanjay, can you answer?
When disease spreads, that is called advanced disease or metastatic disease. So in that situation, there is option of chemotherapy, gemcitabine and cisplatin, and that can be combined with immunotherapy, which we were discussing currently. And combination therapy has got better results as compared to the chemotherapy alone.
Right. Any other question? So, can NPC be fully cured, and what are the chances of coming back? What are the chances of relapse? Dr. Pulkit.
So we basically divide the treatment of any oncological malignancy into curative intent and palliative intent. So anything up to stage 3, we can consider it to treat with the curative intent, when we can radically use the neoadjuvant chemotherapy followed by concurrent chemotherapy plus radiotherapy. So our intent is cured. Now, yes, it can be cured, but what are the chances of coming back? So since it's aggressive malignancy and rare also, so post completion of the treatment, we keep doing 2 monthly or 3 monthly radiological as well as clinical examination. It is being considered that if initial 5 years, if the patient is disease free, then there is a very less chance of disease coming back post 5 years. So we do a follow up, but yes, there is a chance of recurrence even after fully treating a cured patient.
Dr. Pulkit. So, how can a person get treated for NPC, and is it painful or is it complicated, Dr. Amit?
So NPC, as we are saying, is there is a hidden area in our face, that is nasopharynx behind the nose. So there is one specific symptom that can say that person is having nasopharyngeal carcinoma. So there is no symptom specifically associated with NPC. That means there are certain set of symptoms that can suggest that patient can have malignancy, or which malignancy can be NPC. So, for example, if patient is having neck swelling, lymph node swelling, then we can say that patient can have a malignancy, or even infection tuberculosis can have that neck swelling. In that case, we need to do proper ENT examination. We need to first examine locally through the instrument of that ENT doctor that he or she is having. Then, if there is a strong suspicion, there is some mass, then we can get a biopsy from the local lesion or from the neck node lesion. And after that, if there is malignancy proven, then we need to also do staging workup. In that case, we need to offer local MRI or CT scan. If we are suspecting distant metastasis, then we need to do distance screening also, CT thorax or PET CT. So all these investigations are commonly done. None of the investigation is having significant impact on quality of life or any significant pain. For example, certain set of the patient, they come with that biopsy is going to upstage the disease. So by default, that's not the case. Biopsy is going to help us making the diagnosis and further planning the treatment. And biopsy is usually done under local anesthesia, so it's not a usually painful process. And even after we are doing biopsy, we give analgesics post biopsy to reduce the post biopsy pain. So the diagnosis procedure as such is not painful, and you should not be scared that that particular patient is having suspected malignancy and in workup is going to be painful and going to alter quality of life. That's not the case. So we should not propagate that making a malignancy diagnosis is a painful process. So that's not the case.
That's so good to know. So, are there good NPC treatment centers in smaller cities, and how do patients, go there and have access to the treatment? Dr. Sanjay?
Small with smaller cities means at least that city should have a radiotherapy facility, because radiotherapy is a common modality which is employed for treatment of most of these nasopharyngeal carcinomas, except when they become very advanced and where chemotherapy plays a major role. So yes, if there are cancer centers having radiotherapy facilities, especially newer machines, then treatment can be done there also. There is no need to be referred to a major center. However, these cancers, since they are rare, so it is always advisable to be get treated at institute level, at centers where there are all the three facilities are available and multidisciplinary care is available.
Right. Any other question? So I think there's no more question to take. I also believe that improving nasopharyngeal carcinoma care requires early detection, and advanced treatments are coming up. And with awareness and efforts and collaboration, we can have better life and we can save so many lives. So thank you all of you for joining us today and giving the valuable insights. Thank you.
Thank you so much. Thank you.
Thank
Thank you very much. Thank you.